Hello, my name is Rebecca Shen. I'm a fourth year medical student at Duke University, and I'm excited to share with you all today on behalf of my team our project on improving PAD care from a population level approach. PAD care is well established both nationwide and within Duke to suffer from issues of inequity and inadequacy. In particular, for our Duke patients, many of them do not take statin therapy, they're not seeing a specialist provider for their PAD care, or they're still current smokers, and this is leading to many harmful and expensive downstream effects, including hospital stays and amputation. Therefore, the intention of this project is to identify PAD patients early on in their disease course in order to intervene on them in a timely manner that will reduce their risk of experiencing such harmful and costly downstream effects. For our methodology, we utilized a previously developed and validated logistic regression model. This model was found to successfully identify PAD patients in a large health system based on their electronic health record data. Our goal was to both implement this model and crucially add on a clinical intervention component that would change the care and management of current PAD patients within the Duke University health system. Our model was run on a very broad model cohort that included all adult patients that had come through the Duke Health system with a clinical encounter involving at least one of the PAD-related diagnoses codes. A risk score was then generated for each one of these patients in the model cohort to decide who would be most appropriate to move forward in our rounding process. This is the original paper that our model was based on for your reference. And here's an example of what our model output might look like. It includes the risk score generated for each patient, the model inputs that went into contributing to that particular number, as well as we automated a process to pull EHR data that would support the rounding process and let our clinicians tell at a glance which interventions might be most appropriate for each individual patient. And here's a visual representation of the virtual rounding workflow. It begins with the model putting out which patients are most high risk for PAD. After the clinician chart reviews, the patient then enters a virtual rounding process, which includes a discussion between a pharmacist, a rounding specialist, as well as the PAD clinician, who work together to create an intervention plan. The intervention plan is communicated to the patient's primary care physician, who ultimately will be the driver in determining what interventions the patient will end up receiving. In conclusion, we implemented an ongoing population health rounding intervention for Duke PAD patients. Our model is ongoing and it's constantly refreshing patient data, pulling in new patients into the cohort, as well as updating the risk scores for existing patients. And as of this summer, many patients have already entered active discussions, and we've already been able to successfully make many medication adjustments, as well as referrals to smoking cessation clinics, and truly change the clinical management for PAD patients. The pros of our approach is that it's very sustainable. Relatively, it was easy to implement, and potentially it's very high impact for our PAD patients. These are some of the future directions we would like to see our project move in. Thank you so much for listening.